Um, Dear Chairman, dear Professor Wang, for your introduction. Ladies and gentlemen, good evening. Today I'm very happy to share our experience on pathogenesis and its clinical implications for choledochal cyst. Choledochal cyst is common in Asian countries. Today, my talk will be focused on the ectopic dislocation of papillary flutter in choledochal cyst and its correlation with PBMU, biliary dilatation, pancreatic ductal variance, clinical symptoms, and its correlation with the pathogenesis of choledochal cyst. Currently, the etiology for choledochal cyst is still unclear. Douglas regards the choledochal cyst was caused by the weakness of the wall of common bile duct. Based on the animal study, Lewis Pease proposed the combination of the weakness of the wall and the obstruction distal to the wall may cause the dilatation of the biliary system. Babbitt found the pancreatical malunion occurred in the patients with choledochal cyst. So currently, PBMU is the popular hypothesis to explain the formation of choledochal cyst by the long common channel pancreatic juice into the bile duct, destruction of the ductal wall, and the weakness and the inflammation of the cyst wall, and at the end, biliary dilatation developed. However, by PBMU animal model, only fusiform dilatation had been induced, and some patients with PBMU but does not associated with the biliary dilatation. In this case, you can see the PBMU is clear, but no dilatation of the common bile duct. And choledochal cyst can be diagnosed as early as 15th week gestation before the pancreas is matured to produce the effective enzyme. So the PBMU is the etiology of choledochal cyst. This hypothesis is still challenged, and the cause of PBMU is still unclear. Gender regarded the PBMU is related to the faulty budding of the primitive pancreas. And Tanaka proposed the regression of the terminal choledochus and the canalization of W1 ventral pancreas. Attic duct may be the region of the PBMU. And Wang from Hong Kong thought the arrest of the migration of the pancreatical biliary malunion may be the etiology for the choledochal cyst for the PBMU. In 1998, our team firstly found the high incidence of ectopic dislocation of the papilla of flutter in the patients with choledochal cyst. The first study was carried out on 38 patients. 27 of them suffered from the ectopic dislocation of the papilla flutter. And this slide shows the papillary papilla located at the junction between the second and the third part of the duodenum. This slide shows the papilla located at the middle portion of the third part of the duodenum. In this case, shows the papilla at the fourth portion of the duodenum. And in year 2000, as a visiting scholar, I came to Juntendo University School of Medicine to make the collaboration study on the ectopic dislocation of the papilla flutter in choledochal cysts. 38 patients from Beijing Children's Hospital, the other 83 cases from Juntendo University School of Medicine. 13 patients with the hereditary spherocytosis and neonatal hepatitis were selected as the control. In control, the papilla flutter was located in the middle third of the second portion of the duodenum, and no PBMU was found. However, in the choledochal cyst patients, 13% of the patients with the papilla at the middle of the second portion of the duodenum, 19 patients with the papilla at the distal part of the second portion of the duodenum, 30% of the patients with the papilla at the junction between the second and the third part of the duodenum, and 34% of the patients with the papilla at the middle of the third part of the duodenum. The other 2.5% with the papilla at the fourth part of the duodenum. So the patients were divided into two groups. Group 1 with the papilla at the second portion of the duodenum. Group 2 with the papilla at distal to the second part of the duodenum. In order to eliminate the variations in magnification aids between the cholangiographic study, the length index was introduced. It's equal to the active length of common channel divided by the height of the second lumbar vertebral. So in control, you can find the length index of common bile duct are same, no difference between the patients younger than 6 months and older than 6 months. And the length of common bile duct are much longer in group 2 than that in control and group 1. This slide shows the location of the papilla in the second portion of the duodenum, or in the group 1. You can see length index about 0.65 and 72 with the papilla flutter at the second part of the duodenum. This slide shows the papilla in the group 2. You can see this papilla at the junction between the second and third portion of the duodenum, with the index longer as 1.07. And in this case, with the papilla at the middle portion of the third part of the duodenum, with the length index 1.94. This case with the papilla at the fourth part of the duodenum with the length index 0.92. So the length of common channel in group 2 were significantly longer than that in group 1. and the diameter of common channel are in the group 2 and the group 1, no difference in group 2 and group 1. In order to investigate the papillary water with the dilatation of the common bile duct, the study was carried out on 327 patients. The patients were divided into 3 groups. Group 1 with the papillary in the middle third of the second part of duodenum. Group 2 papillary from the distal third of second part to beginning of third of the third part of duodenum. Group 3 with the papillary from the middle of third part to fourth part of duodenum. 能不能把这个删这个挪掉？这个我看不看？哦哦，you can see for cystic dilatation, the 65% of the patients in group 1 with cystic dilatation, 78% of the patients in group 2 with cystic dilatation. However, 90% of the patients in group 3 with the cystic dilatation. The incidence for cystic dilatation are much higher in group 3 than in group 1 and group 2. And also, the length and the diameter of the choledochal cyst are significantly larger in group 3 than in the other 2 groups. To evaluate the cause of the dilatation of the common bile duct, the manometer study was carried out on 32 patients. It was found that the dilatation of common bile duct was caused by the intraluminal pressure in the common bile duct. This slide shows the resting pressure and the perfusing pressure in the cystic type of dilatation is higher than that in the fusiform type. And the diameter of the distal common bile duct is narrower than that in the fusiform type. And the level of amylase level in gallbladder lower in cystic type than that in fusiform type. And the resting pressure and the perfusing pressure in the cystic type are significantly higher than that in the fusiform type. And pathological findings in the dilated cystic wall include infiltration of the inflammatory cells, interstitial fibrosis in the dilated and thickening wall, and epithelial exfoliating. And the fibrosis of the cystic wall was more severe in the cystic dilatation than in the fusiform dilatation. The fibrosis was positively correlated with the diameter of the choledochal cyst. And also the liver fibrosis was also one of the characteristic changes in the patients with the dilatation of the common bile duct. In order to investigate the association of the ectopic dislocation of the papillary filter with pancreatic ductal development, The pancreatic duct variations were divided into four types. P1 with the complete pancreas division, P2 with incomplete pancreas division, P3 with a connection between the accessory duct and the main pancreatic duct. Type 4 P4 without the connection between the two ducts. It was found that in normal P1 and P2 variants were not occurred in controls. And you can see P1, P2, and P3 variations in choledochal cyst group are significantly higher than that in controls. And in the group 2, the percentage of P1, P2, and P3 variations are significantly higher than that in the group 1. And also, 7.9% of patients in group 1 associated with the pancreatic ductal dilatation. However, 28% of patients in group 2 suffered from the pancreatic ductal dilatation. The difference was significant. The diameter of the pancreatic duct in group 2 were significantly larger than that in group 1. The age at the diagnosis and at surgery are significantly younger in group 3. And 62% of the patients in group 3 were diagnosed prenatally. This incidence was significantly higher than that in group 1 and group 2. And the patient in group 3 with the youngest age and the highest rate of the prenatal diagnosis. And the level of GGT, total bilirubin, direct bilirubin, and the TBA were higher in group 3 than the other two groups. And the more distal location of the papilla of water, the high incidence of totally full intrahepatic dilatations occurs. You can see in group 1, the type 4 dilatation occurred in about 8%. In group 2, it about 9%. However, in group 3, about 12% of the patients associated with type 4 type of intrahepatic ductal dilatations. However, the incidence of pancreatitis, vomiting, and abdominal pain more likely occurred in the second group, in group 2 of the patients. In normal, initially, the hepatic diverticulum and the dorsal pancreas originated in the middle of the duodenum. With the rotation of the duodenum, the dorsal pancreas and the ventral pancreas fused together, and the ventral pancreatic duct fused with the dorsal pancreatic duct to form the main pancreatic duct. In the end, the common bile duct and the mean pancreatic duct insert into the duodenum through the papilla of Vater. Our study demonstrates the high incidence of the dislocation of the papilla of Vater in choledochal cyst because the opening of the papilla of Vater represent the orifice of the hepatic diverticulum in the early embryo. So we propose the distal ectopic budding of the hepatic diverticulum occurs in the patients with choledochal cyst. So the lung gap between the ventral pancreas and the dorsal pancreas developed. With the fusion between the ventral and the dorsal pancreas, the junction between the hepatic duct and the pancreatic duct will be stretched and elongated, leading to the lung common channel. So the ectopic dislocation of the papilla of Vater indicates the ectopic distal budding of the hepatic diverticulum in the early embryonic stage. So the lung gap between the ventral pancreas and the diaphragm and between the ventral and the dorsal pancreas developed. The common bile duct was stretched, leading to the stenosis and the long common bile duct, resulting in the biliary stenosis and the dilatation. The common channel was stretched, leading to the long common channel, and the PBMU formed. The lung gap between the ventral and the dorsal pancreas duct results in the delayed fusion of the ventral and the dorsal pancreatic ducts. So the variation of the pancreatic duct was produced. So, ladies and gentlemen, in conclusion, our study demonstrates the high incidence of choledochal cyst patients are combined with the ectopic distal location of the papilla of Vater. The more distal location of papilla of Vater, the longer common channel of PBMU results. This ectopic dislocation of the papilla of Vater was closely correlated with clinical characteristics such as larger size, cysts, early age onset, more severe symptoms, and liver damage. The ectopic distal budding of the hepatic diverticulum during the early embryonic life may be an etiology factor in the formation of the choledochal cyst. Thank you for your attention. Welcome everyone to join the Beijing 2028 AAPS meeting. Thank you again. Thanks.
Thank you, Professor Long Li. I think this was a very out of my depth kind of talk, all very basic science. I didn't even think about all these developmental issues when I operate on all my cases. So if there anyone online who got any question, I see one question from Akshay asking, is it right to say that only major papilla is abnormally located and minor papilla is most of the time constantly located in the normal location?
Uh, yes, the mean papillary of water uh, 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 usually dislocated to the second portion of the duodenum, but the minor papilla uh, sometimes are proximal to the papilla of water, and if the distance between the two papillars become longer, this will interfere with the fusion of the uh, ventral pancreatic duct and the dorsal pancreatic duct, resulting in the series of malformations on the PBMU and the pancreatic duct. Yeah.
Uh,
Vikesh?
yeah. So, a lot of congratulations to Professor Lee for such an in-depth, assessment of the anatomy and embryology of choledochal cyst. I have a question to you, Professor Lee. What is the practical application of this important knowledge in terms of distal dissection of the lower end of the CBD, and how often it predisposed to certain types of unusual injuries to the pancreas or the pancreatic duct, and how do you evaluate intraoperatively these types of variations, and how do you go about it in your surgical techniques?
We made a study according to our intraoperative cholangiography. Uh, yes, during the cholangiographic technique, we made several repeated the cholangiogram to make sure uh, the good enough that the cholangiogram had been made. According to the cholangiogram, so we made the investigation on the biliary system and the pancreatic system. Uh, yes, please, again, the question again.
What about surgical application of this particular knowledge about anatomical variations at lower end?
Yeah. Oh, yeah, very important question. For the ERCP, sometimes if you thought the papilla of water in normal uh, anatomy location, so sometimes you cannot find the papilla of water in the second part of the duodenum. On such occasion, if you have the idea about high percentage of the papilla of water located distal to the second part of duodenum, you may insert the endoscopy deeper to the third part or fourth part of the duodenum. This is one point. The second point, during the operation, if the papilla of water located in the third and the fourth part of the duodenum, that means the distal part of the choledochal cyst is very deep down to the pancreas. So the difficulties of surgery can be predicted just before the surgery, and during the surgery, you should make the wider exploration to expose the distal part of the choledochal cyst, because it may not on the right. Sometimes the distal part of the uh, common bile duct located to the left, very deep down to the pancreas. So, so if you have this idea, you can make the better uh, dilatation for the distal part of the choledochal cyst.
And one more quick question. Is there increased incidence of intraductal stones with long common channel? And do you do a cholangioscopy intraoperatively, like many Japanese do?
Yes. Uh, for every case, in our center, we perform the cholangiogram. If we found the protein plug in the common channel, and uh, or sometimes the common channel was completely occluded by the stone. On such occasion, we performed intraoperative endoscopy to remove these stones. Not for everyone, but for the patients with the sign of stones in the common channel. Thank you for your question.
Thank you.
Could I get to Satoshi? For those of you who online who don't know Satoshi, he's the chief of surgery in Kagoshima, and he's the current president of IPEC. And he's obviously an expert in laparoscopic surgery as well. With regard to those very large cortical cysts and those going into the pancreas, how do you deal with the situation, Satoshi?
Sorry, what did you
For
say?
for the very large cortical cyst extending into the pancreas, how do you go behind the pancreas and do the dissection safely?
Oh, huge cortical
Yeah,
system. Uh, the how about the age, the infant or older?
I don't know. But I've got a trick question for the IPEC president.
So, the large type, the cortical system is I think the easy for treat for the dissection of the cortical system. So, sometimes such type of cortical cyst is don't have the mud junction or mud union of the pancreatic duct. So I think so. So I from my question for the Professor Lee, okay,
Yeah,
yeah. So I understand your theory of the today's lecture. So the ectopic opening of the papillophata is a primary pathogenesis of the corticocyst, you say? Yeah. So we sometimes experience the two types of the malunion. The one is a common bile duct straight to the duodenum, maybe the more distal type. This uh, uh, this type is mainly the common bile duct. Pancreatic duct is fusion to the uh, uh, common bile duct. But more another type, pancreatic duct straight to the opening to the duodenum. The corticocyst is opening to the middle of the pancreatic duct. These two types was different, I think, different type of the malunion. Can you explain these different types of maljunction type of the malunion? Your
yeah,
theory, yeah, first type, I think your theory is applicable for the first type, but second type, what do you think about?
yeah. You very good questions. I think your two type of pancreatical malunion is also re, uh, related with the location of the papillary flutter. And if the papillary flutter in the second part of the duodenum, uh, so the common bile duct will connect it straight to the pancreatic duct.
Yeah,
If the papillary flutter distal to the second part, That means the common channel will go to the street, down to street, the direction. On such occasion may be the pancreatic duct connected straight to the distal common bile duct. The food type is dependent on the location of the papilla of water.
Okay.
Yeah.
Depends on the position of the papilla fata.
Yeah.
You explained that.
Yeah. Thank you.
Different position of the papilla fata is different malunion type.
Yeah.
Okay.
Yeah.
We've
Good
got one
question.
question online for you, Long. It's Mohammed Sharif from Pakistan. He's asking that he sees hepatic artery crossing in front of the common bile duct in a 5-year-old girl. What is the experience about this, and what is the etiology?
The artery in front of the
Common bile duct.
common bile duct. Yes. In our series, it's this is the right hepatic artery in front of the common hepatic duct. It takes about 20% uh, of the primary surgery for choledochal cyst, about 25% for the redo surgery. Redo surgery. So the incidence between the normal population and the choledochal cyst for the anterior location of the right hepatic artery is nearly the same. Nearly the same. Even in normal population, the right anteriorly located right artery is common. So I don't think the anterior location of the right artery is associated with the etiology of choledochal cyst. But if it occurred in the choledochal cyst, it can cause the complications. It may result in the obstruction of the common hepatic duct if you do not remove the artery from anterior to posterior of the anastomosis. So in our series, if you find that the anterior located right hepatic artery, you should remove at the primary surgery from the anterior to the posteriorly. Yeah.
He's got a second question for you. So what is the experience of Merit-C syndrome in children?
What?
Merit-C.
Meaning the gallstone blocking the duodenum.
对对，gallstone, yeah. In the older children, we see every year 1 or 2 cases in our center. We found the gallstone to the just the in the distal part of the common bile duct, resulting in the obstruction of the biliary system. On such occasion, we perform the ERCP to remove the stone. Yeah.
Okay.
So, can we move on to the next talk if questions are over, Professor Ken?
Yep, we can. I think we should not delay Professor DIAO anymore.
Yeah.
She has been working with Professor Long LI for many years. I'm sure she's now a world expert on her own, and she's done also very many cases of with cyst. let's go turn our attention to Professor Mei DIAO's talk on laparoscopic management of choledochal cyst. Mei, floor is yours.
Okay. Good morning, good afternoon, and good evening, Chairman, ladies and gentlemen. Thank you for the AAPS for education. This is one of the major nations with high incidence in Asia.
But your microphone is not working that well at the moment, Mei.
Microphone. Right.
So choledochal cyst is one of the major congenital biliary malformation with high incidence in Asia. Besides the distal obstruction, PBMU, the combined anomalies of surgery. It is benign disease, reduce surgical to
Professor.
行不行？这行了，这行。
Okay, the sound is better. Let's see. Sounds better.
Okay, so maybe move on to the next slide. So everyone can hear me?
We can hear you, and we can see that you're Long Li now as well.
Okay. So okay. Delayed primary surgery is often attributed to the asymptomatic prenatally diagnosed CDC. Typical symptoms like abdominal pain, vomiting, fever. Estimation of severity and aggravation of biliary obstruction, misdiagnosis of sealed perforation, misunderstanding of external biliary drainage, or ERCP. Next slide. So delayed reduced surgery often because of difficulty of reduced surgery caused by adhesion of the deranged anatomical structure. Imaging showed the IHD dilatation plus stone formation, but normal lab tests or asymptomatic cases often refer to observation with the medication treatment, which induced severe biliary obstruction, even liver fibrosis or cirrhosis. Next slide. The timing for primary surgery. With the development of ultrasonographic study, the percentage of prenatal diagnosed CDC increased with the year from 16% in 2010 to nearly 50% in last year. The amount of sludge in the cyst induced complete obstruction, which leads to the severe liver damage and perforation. The earliest one occurs in our series. The liver cirrhosis occurs at 2 months after birth, and the perforation occurs 2 days after birth. Next slide. And the perforation incidence decreased with the age. Next slide. Comparison between the CDC neonates and the infants with perforation show the percentage of perforation is 30% in the neonates, significantly higher than that in the infants. And liver cirrhosis in infants is 25%, significantly higher than the neonates. And premature delivery in the neonates is higher than that in the infants. So the population is a sort of a self-protection. It sacrifices the biliary tract to save the liver function to avoid liver cirrhosis. Next slide. The liver fibrosis in the perforated CDC, the pathology show the 42% perforated CDC had liver fibrosis, and 82 occurs in the infants younger than 1 year old. Next slide. Previous study also show the elevated GGT level is related to the liver fibrosis. Our study show the elevated GGT level is related to the perforation and can be used as an indicator of incoming complete perforation. Next. We need to pay attention to those symptomatic prenatally diagnosed CDC. Some of them have sealed perforation. It's a mask of their symptoms, but they still develop the liver cirrhosis and the portal hypertension within a short period. This cases is a 4 months prenatally diagnosed CDC. The right side show the liver cirrhosis and the perforation. And delayed surgery for prenatally diagnosed CDC induced cirrhosis and finally leads to the liver transplantation. This is a 6 months old girl. Even though she has definitive surgery at 6 months, still have a liver failure after 1 month of surgery and wants liver transplantation at 6 months. And previous study in other center also show the liver transplantation in CDC infants because of the liver failure. Next and next. Our study show although the CDC neonates with higher perforation rate, the laparoscopy can be successfully used in one-stage surgery for CDC neonates. It brings a new horizon of management for CDC neonates with perforation. Next, the video. And this video show 18 days girl. He detected hilar cyst at the gas station 4 months. Now he has sealed perforation in the right side near to the stomach. So you can see the left side, the ultrasonographic study, this is the perforation site with the bell side. The left side image show the amount of sludge in the cyst, which induced sealed perforation. And the second image is the CT scan. The pseudocyst is located in the stomach cake situation in that position. So at a primary or when he admitted to our hospital, we misdiagnosed the pseudocyst as the stomach. Intraoperative cholangiogram showed the stomach was pulled up by the pseudocyst. Next slide. Even for the type A CDC, if we do the early surgery before the IHD severe dilation, 90% can obtain the good results after wide HD. Next slide. This is the CDC, type 4 CDC in different ages. Timing for redo surgery. The causes included the cholecystolejejunectomy, cystolejejunectomy or HD, post-OP biliary obstruction, residual cyst at the proximal or distal side, the bile leak caused by aberrant hepatic duct or anastomotic skill, hemorrhage or Rook's loop obstruction. Next video. The reduced surgery can be done by the laparoscopy. This is the revision of cholecystogenostomy after dissection of the adhesion. We start to cyst dissect from proximal to the distal side. The dissection carried out along adjacent to the cyst wall to avoid injury, and this the cystoscopy to clear the proton plug in the common channel, and the distal side ligated by the hemlock, and then transected. The posterior wall also dissected along adjacent to the cyst wall, and the CHD stricture was split to the proximal dilated side, and the stone was removed. This is the aberrant HD, so we suture the lateral wall of CHD and aberrant HD to form a one stoma for the HD. Next slide. Post-OP biliary obstruction usually caused by congenital and technical factors, including the aberrant RHA anteriorly comprising the proximal CHD, unrecognized HD stricture, and anastomotic stenosis. Next slide. This case is aberrant right hepatic artery anteriorly crossing the anterior wall of the common hepatic duct and induced posterior post-OP biliary obstruction. And right side, this case also have aberrant HD. They do the AHD jejunostomy. After the surgery, he has anastomotic stricture. And this patient has multiple HD stricture plus residual proximal cyst. The right side, you can see the residual proximal CDC. Above this is the primary CHD stricture. We do the ductoplasty and remove the stones. And then we do the redo HD. Next. This is the type 4A choledochal cyst. The stenotic segment extends to the IHD, distant to the hepatic hilum. The primary surgery we do the robotically, but after the surgery, the patient still have biliary obstruction and the stone formation because the relative narrow at the right left and right hepatic duct orifice. So we do the open surgery for the wide HJ. Liver fibrosis can occurred in the cases with post-OP biliary obstruction. It can occur at 2 months after surgery in small infants. This is 3.5 months boy. Post-OP he has a colic stool and jaundice. The GGT elevated to the 543. Use the antibiotics to 4 weeks, and then GGT level increased to over 800. So in the reduced surgery, we can see the liver cirrhosis in the surgery, and the pathology results also show the fibrosis grade 3 to 4. And this post-OP biliary obstruction caused by aberrant RHA comprising CHD and the residual proximal CDC. This 8-year-old girl, post-OP 2 years, she underwent redo surgery, and pathology results show the liver cirrhosis, portal hypertension with the fibroscan over 15 kPa. So next slide. So we compared the mild and severe liver fibrosis group in redo surgery. The liver damage induced by post-OP biliary obstruction, the younger infants was severe than the older children. The earlier onset of symptoms, the severe biliary obstruction and liver fibrosis. The severity of liver fibrosis is related to the severity rather than the duration of the biliary obstruction, i.e. the severe biliary obstruction can induce severe liver fibrosis within a short period. This slide shows the redo surgery. We can see if the patient have a normal lab test and imaging show the IHD dilatation and residual NO residual intrapancreatic cyst, the redo surgery, after redo surgery, the pathology results show more grade 3 to 4, i.e. the severe liver fibrosis in these two groups of patients. And previous study also showed the delayed redo surgery have at least liver cirrhosis in over 12% of patients. So the early redo surgery, particularly in younger infants, is advocated to avoid irreversible liver and biliary damage. And the redo surgery is recommended to the following conditions. Next slide. This laparoscopy redo surgery in CDC, you can see the combined right hepatic artery anteriorly compressing the CHD and the left and right side, left and right hepatic duct outer face stricture. It can be treated by the laparoscopy successfully. And actually, this patient already underwent 3 operations, both in laparoscopy and open surgery before the final redo surgery in our center. So we still can try the redo surgery in minimal invasive way. When compared the laparoscopy and the conversion group in redo surgery, and the age of redo surgery in laparoscopy group is younger than the conversion group. The interval between primary surgery and the onset of symptoms, and the interval between onset of symptoms and the redo surgery in laparoscopy group is shorter than the conversion group. Next. The index of biliary obstruction in the laparoscopy group is significantly higher than those in the conversion group, i.e. the severity of biliary obstruction is not the contraindication of laparoscope. Laparoscopic redo surgery in treatment of post-OP biliary obstruction, the success rate of laparoscopy redo surgery is related to the age, duration, rather than the severity of the biliary obstruction. And the younger patients with shorter duration of biliary obstructions, the higher success rate of laparoscopy redo surgery. Improper transaction level, including the proximal and the distal. this slide shows the residual pancreatic CDCs. It can be treated by the routine way use from the posterior pancreas. If the patient transect the segment of intrapancreatic at the superior portion of pancreas, we can dissect from a we can start the dissection of distal residual cyst from a super portion of pancreas. If the patient combined with aberrant pancreatoduodenal artery comprising the posterior residual cyst, or hardly detect the cyst in direct vision or by ultrasonographic study, we can incise the duodenum opposite side to the papilla of Vater and use the 6-5 retro probe from the Vater and heading to a common channel and distal differentiate with the surrounding tissue and irrigate the common channel and the pancreatic duct using the normal saline irrigation. Remove the protein plug and the pancreatic stone. After that, we suture the distal side to prevent the pancreatic leak. The carcinoma is in the residual cyst is 14%, and incomplete excision increase urinary cancer. Next slide. The treatment outcome of adult with this residual intrapancreatic cyst showed 83% with malignance died after redo surgery. Improper surgical procedure, including the HD cystoantral duodenum or jejunostomy, cholecystogenostomy. The HD versus HD show the complication rate. HD is 42% and HD is 7%. HD also often associated with gastric reflux, gastritis, and malignance. Next slide. The cystoduodenum or jejunum stomy also show the recurrent cholangitis, anastomotic stricture. Post-OP malignancy is about 30%, mortality is 11%, and over 50% required reduced surgery. So in summary, the efficacy of choledochal cyst treatment is related to the recognition of the pathophysiology, OP timing, and technique improvements. By the way, we mentioned the AI in laparoscopy CDC, and Professor Hooker Hill, the ex-chair of APAC, would like to cooperate with AAPS to do some AI study on the CDC surgery. So if anyone of you have interest, you can contact with him by the email address or me. Thank you.
Thank you, Mei. I also know that Holger is online on a webinar, so anyone wants to collaborate with him, just email him. Vikesh or Satoshi, do you have any questions?
Yeah, so it was an excellent presentation by me, and I congratulate you for a commendable job. in dealing with the complications of choledochal cyst. Looking into your huge experience, I would like to ask one question, because other question about HD versus HJ you already answered. So my question to you is about type 4A choledochal cyst, where you recommended excision of the cyst and reconstruction. What is your experience about malignancy in such cases, and what about liver cirrhosis and failure leading into liver transplantation in how many patients? Percentage of patients? Me.
I think they're stuck again.
Are
you back online, Mei?
She's still there, but she's not audible to us.
Long is online.
So even Professor Lee can answer that question.
Satoshi, you can answer on behalf of the Japanese.
What is the question for the Professor?
My question was related to type 4A choledochal cyst.
Yeah.
Where me recommended excision of the cyst and leaving the dilated portion at the hepatic porta. So why not a liver transplantation for a severely dilated system primarily? What about incidence of malignancy in such cases when we leave that dilated portion there?
So I don't know that I don't have the exact data, but we corrected the past 10 years Kyushu Island cortical cyst 240 cases. The only one case is malignancy.
Yeah,
only one.
right.
Yes.
But the incidence of malignancy, which me has shown, is quite high. So
yeah,
that
yeah,
is
I think so.
Surprising for us, because in our region we hardly see any malignancy, although we recommend complete excision of the choledochal cyst. And secondly, the high incidence of complications after a hepaticoduodenostomy is also very surprising, because it has, with the advent of laparoscopy, hepaticoduodenostomy has grown a lot of popularity. Yes, there is a lot of biliary gastritis, but it is usually asymptomatic. And me talked about some malignancy after hepaticoduodenostomy. So I would like to know what type of malignancy happens after hepaticoduodenostomy. Is it stomach malignancy or what? It's never, I mean, actually, I'm unaware of that.
Because in our sorry.
Yeah. Go ahead.
Go ahead.
You first.
Ladies first.
Okay. So in our center, we do the laparoscopy each day for all the patients. As you know, just now I mentioned about as early as possible, and some of them do it at a young infant period. So we have finished 3,500 over that. So till now, we didn't find any malignancy. But the cirrhosis, we truly found in them, particularly in the perforated group, is about 42% in those patients have liver cirrhosis.
What about malignancy after hepaticoduodenostomy? You spoke about malignancy after hepaticoduodenostomy in your slide. What type of malignancy happens?
I did this malignancy from the previous literature, and I discussed this situation with Professor Naomi when he visited in our center. I asked him some literature from Japan also report after HJ, they also the patient also encounter the malignancy. So his reply is the transaction level is not proper. Because the proximal residual cyst or the distal residual cyst will induce the malignancy. So the transaction level is very important for the long-term results.
I think the most important thing for all of us is to have the complete resection of the cyst. And for our series, I've never seen one. Over the past, we got a complete record of past 50 years of all the cases done in Hong Kong, I've never seen a case with cancer. So same with Satoshi. So I think overall, if you don't resect, then yes, but if you resect like us, ped surgeons, then the likelihood of it having cancer would be very, 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 very low.
One just question on a lighter note, maybe my last question to me. As I saw, all of your pictures and surgery videos were on single incision laparoscopic surgery. So, like the proponent of single incision laparoscopic surgery, do you recommend robotic surgery which uses like larger ports and too many ports? So, what is your opinion about single incision versus conventional 3 or 4 port laparoscopic surgery versus robotic surgery in choledochal cyst?
Thank you for your question. And the parents also asked me the similar question, you know, how to choose which way is proper. I think the surgeon, if you you choose the way you're familiar with. So, but if you have adequate cognition about this disease, the pathophysiology, and you treat it in proper way, the long-term results is good.
So you answered like a typical professor. Thank you very much.
Thank you.
No,
Very political.
Vikesh, I've been doing laparoscopic workshops in China with Long since 2007, and we've been training over 3,000 sort of attendees so far. And every single time in the workshop, he's shown us how to do single incision lap surgery. And I always tell the attendees, do not copy him because you're not Long Li. We're mere mortals.
So I saw a lot. I worked with Professor Nguyen Lim for some time, and I saw Dr. Sohn doing excellent single incision laparoscopic surgery there. But we cannot copy his steps.
Do what is the safest for you.
Correct.
That's my wisdom. So I think I've got one person online asking if they can visit Professor Lee's center for 2 to 4 weeks for observation.
Oh, definitely, you're welcome. All of you, welcome to
So
our.
do you have your contact details, Mei?
Yeah, I leave my email address.
Show us again. Show us again. Show us again.
The last,
You can go to Mei Center, you can go to my center or Satoshi Center or Vikesh Center.
Yeah, and you can
Most welcome.
You can join our surgery, single incision laparoscopic surgery.
Do not copy single incision. Do not copy. Where is your email?
It's PS something.
Yeah.
Half of it I remember.
Yeah, here.
PS
It's a
3000.
homeless email.
Yeah, here. PS.
At bottom, PS 3001.
Yeah.
Okay. So if you still don't remember, you can look on the flyer and you can email Adrian. You can get in touch with all of us through Adrian on the flyer.
Yeah. Okay. Thank you, Adrian. You did a great job.
Yes, no problem.
So
contact me, yeah.
Last question. What is your experience of dealing with type 2 and type 3 choledochal cysts?
In our center, actually, we didn't have type 2 or type 3.
Vikesh?
Oh, I don't have much experience about it. We typically see a fusiform choledochal cyst. Even type 4 is very less common in our scenario.
Satoshi?
So mainly type 1 or type 4, less common. Type 2
Yes.
to type 3.
Yeah. I think we've seen one type 2 and one type 3 in Hong Kong, and type 2 just a clip of the type 2. Type 3 had an open duodenum, do it from the inside. But anyway, I think we've been going on for an hour and 20 odd minutes, and it's way too late for Satoshi. He's half asleep. I need a glass of wine before I go to sleep. So thank you very much for everyone for joining our very first AAPS webinar. I'm sure that we'll organize another one in a few months' time and get out to everyone and let everyone know when and the topic, when it is and what it is. And once again, thank you to Professor Long Li, Professor Mei DIAO, and my co-panelists, Satoshi and Vikesh, and Adrian for helping do the flyers. As we'll see you all soon again. Goodbye, everyone.
Bye-bye.
Good night.
Thank you.
Thanks so
Bye.
much.
Thank you. Thank you very much.
Thank you so much.
Thank you. Okay.